Hello, my name is Brintha Enestvedt, and I'm a practicing gastroenterologist at Temple University in Philadelphia, Pennsylvania. On behalf of my co-authors, I'm going to discuss the results of a research study to be published in Gastrointestinal Endoscopy entitled Location, Location, Location. Does early cancer in Barrett's esophagus have a preference? In this current study, we examined the circumferential predilection of high-grade dysplasia and intramucosal carcinoma in a clock face orientation in the esophagus. The main finding of our study was that there was a marked increase in the prevalence of such lesions in the right hemisphere of the esophagus. Before I go further, I wanted to share with you who my co-authors are. Ricardo Lugo, an internal medicine resident at the University of Pennsylvania, Pari Shah, an advanced endoscopist currently at Memorial Sloan Kettering, Charlie Guarner Argente, faculty at the Hospital of Santa Cruz Sant Pau in Barcelona, Spain, Emma Beth Firth, expert pathologist at the University of Pennsylvania, and Gary Falk and Greg Ginsberg, both gastroenterology faculty at the University of Pennsylvania, who both treat a high volume of Barrett's patients. Take a step back to a few things we know about Barrett's esophagus. It is a premalignant condition of the esophagus whose prognosis is dependent on the presence and grade of dysplasia. In this context, early cancer is defined as high-grade dysplasia and intramucosal carcinoma, and clearly these lesions carry a significant risk of progression to invasive cancer. We also know that Barrett's esophagus patients who comply with the structured endoscopic surveillance program have earlier detection of esophageal adenocarcinoma and improved survival compared with those who do not undergo surveillance. The endoscopic exam should include inspection en face and in retroflexion with both white light and NBI imaging, with a high level of scrutiny for subtle nodularity. Inspection time has also been shown to play a significant role in the detection of lesions in Barrett's esophagus. As a tertiary care center, the University of Pennsylvania receives a high volume of referrals for multimodal endoscopic therapy for early cancer arising in Barrett's esophagus, including radiofrequency ablation and endoscopic mucosal resection. This made our center highly suited for the study of pathology and management trends in Barrett's esophagus, with a special focus on early cancer. So why did we do this specific study? Well, based on two prior studies in 2007 and 2012, that show that the majority of high-grade dysplasia and intramucosal carcinoma occur in the 12 to 3 o'clock or 2 to 5 o'clock wall of the esophagus, and combined with our long-term experience from scoping many patients over the years with these pathology, we hypothesize that high-grade dysplasia and intramucosal carcinoma in Barrett's esophagus are found more frequently in the right hemisphere of the esophagus, that corresponding to the 12 to 6 o'clock position. So now the important stuff. What does this mean? Why, and who really cares? Well, our study confirms the findings of two prior studies by Peck and colleagues in 2007 and Karyawasam in 2012. There is a predilection of early neoplasia to these regions, and our study expands on the prior studies by the striking predominance of 84.9% of lesions in the 12 to 6 o'clock hemisphere of the esophagus. These findings thus provide support for enhanced scrutiny of the right hemisphere of the esophagus during endoscopic surveillance, and support sampling from these areas with added rigor. The elephant in the room is why. Why is there a right hemisphere predilection? Well, to be frank, we are not entirely sure at this point. In the past, several theories have been proposed. The increased number of right hemisphere lesions may be representative of detection bias due to the more favorable visualization and ease of biopsy in this area. Prior studies have also described an increased prevalence of mucosal breaks in the right hemisphere in patients with LA class A or B esophagitis. And even in patients with non-erosive reflux disease, there are certain histologic mucosal changes, including thicker basal cell layer and more intercellular space dilatation, that occur more frequently in the 3 o'clock position. This is consistent with the location of early cancer in BE described in the present and prior studies. There are times in medicine where we observe a phenomenon but don't quite understand why it happens. And that's kind of where we are now. We've observed a significant trend, and our hope is that it will spur further research to explore an underlying etiology. Nonetheless, this is the largest study to date to describe the circumferential location of early cancer in Barrett's esophagus. So how do we use this information? Well, I think knowledge of this striking predilection for advanced histology in Barrett's esophagus for the right hemisphere of the esophagus and targeting surveillance biopsies in this region may lead to greater detection of these advanced lesions and thus will impact image-guided therapy. Once again, on behalf of my co-authors, thank you for this opportunity, and we welcome any spirited electronic discussion about this topic by contacting any of us.